I'm Ali Smith.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us to reignite your passion for primary care.
Welcome to the Cheering on Team GB from our living rooms episode of the Primary Care Pod from Red Whale.
The Primary Care Pod from Red Whale.
It's been another bumper month of Free Pearls content, so it's another 2 podcast episodes month, and we'll cover half the pearls this week and the other half next week. And as you've probably worked out already, this month we have a guest co-presenter in the shape of the fabulous Ali Smith, because Caroline is on holiday. So welcome, Ali, and can you tell us all a bit about yourself, please?
Yeah, sure. So I work as a part-time GP in Cheshire. I write and present content for Red Whale, and I'm also a mum to a 4-year-old and an 8-year-old who are at home on school holidays with me at the moment. So there's a lot of juggling going on. And I did come to this recording straight from a very sweaty soft play, but it's fine. I'm here and I'm raring to go.
Whew. So yes, nice and calm now. Take a breath. It's all going to be good. And so for everybody else, you might want to grab your preferred drink of choice or your trainers, clutch your pearls, and let's start with the headlines. Here's what's coming up this week. Seeing reds with exercise. The sun is out at times. Wimbledon has been and gone. The Olympics are here. Something about football. It's the perfect time of year to be more active. There are many benefits to physical training, but also some things that we should be aware of. Would you spot reds?
Why does familial hypercholesterolaemia matter? Because untreated, 50% of men and 30% of women with the condition will have had a myocardial infarction by the age of 60. So this is an area where we can make a big difference.
And here's what's coming up next week. I think he might have worms. All things helminth revealed. Okay, it's not glamorous. It's one of those where else would you learn this but Red Whale topics. But worms or helminth infections was one of the most common unreturned searches on Red Whale Knowledge. So we wrote you an article and released it as a pearl, which we'll discuss in next week's episode.
We see a lot of discharging ears in primary care, and we often put these down to otitis externa. Otitis externa is common, but there are other causes of otorrhea we don't want to miss. We'll take a closer look at some of the pitfalls in diagnosing otitis externa and why these consultations are not always as straightforward as we might think.
Okay, so let's start with our first pearl and reds. Now, I found this fascinating to read, and it took me 10 minutes, so medium length, and it's not something that I knew much about. Okay, I'll be completely honest with you. Before reading this and researching for the podcast, I'd never heard of reds. Does that make me a bad GP? I hope not. Of course, I'm aware of the principles involved, and it all makes sense when you think about it, but I didn't know the term. So, as I throw myself at the mercy of our fabulous listeners, Ali, what did this one mean for you?
Well, I'm exactly the same as you, Nick. I'd never heard of this term before. The only Reds in sport that were on my radar before today were Manchester United. But I was vaguely aware of the concept of periods potentially stopping and bone health being at risk in young female athletes, I think. But what I didn't know is that actually, while those features are important, Reds is a lot bigger than that. It's a multi-system thing, and it can affect men too. So that was really interesting.
Yeah. So, relative energy deficiency in sport, or REDS, is the newer comprehensive term that incorporates the female athlete triad. And we're going to review the condition and identify 5 pitfalls to avoid. The written pearl is based on a BJGP review on REDS, which is from 2022, the most recent International Olympic Committee statement from the British Journal of Sports Medicine in 2024, and some older articles which we'll reference along the way, and they predate the name changes. Now, the term REDS refers to impaired physiological function resulting from relative energy deficiency. It can have effects on multiple systems. Now, if you're a more visual learner, then I recommend that you have a brief look at the written pearl because it's got a great diagram to help you remember all of this. At the centre of the diagram, there is a big red circle, and inside of that, it says the many consequences of REDS. And pointing away from the central circle, there are 9 chunky arrows which are labelled with a different consequence of REDS, and they are mental health, menstrual, bone, endocrine, metabolic, growth, immune, cardiovascular, and gastro. So, Ali, what's meant by relative energy deficiency?
Well, Nick, that's just a fancy way of saying that a person burns more calories than they consume for a significant length of time. And a short-term period of energy deficit isn't usually a problem. For example, the reduced appetite some people experience during a period of acute stress. But prolonged energy deficit can lead to problems. And interestingly, newer evidence suggests that specific low carbohydrate availability may confer a disproportionate risk of developing REDS when compared with a more balanced energy deficit with a greater carbohydrate content.
And who does REDS affect?
Well, while we refer to sport and athletes in the article, it's important to point out that this disorder may actually affect any person who's exercising, ranging from elite athletes to recreational, keep fit level people, and to any people who have very physically active jobs. So that's our first pitfall. You don't have to be an athlete to have REDS. It can happen in those who exercise across any activity, at any age, and at any ability. Nick, can you tell me about disordered eating in REDS?
Well, I certainly can, Ali. The disordered eating in REDS may be somewhere on a spectrum ranging from near normal eating to disordered eating that meets the DSM criteria for an eating disorder and all the sequelae of this. Now, if you want more information on eating disorders specifically, then if you're a member, there is an article on Red Whale Knowledge all about them. And if you're not a member yet, then listen out for the information on how to get a 10% discount, which is at the end of the episode. Now, in some athletes, a formal diagnosis of an eating disorder may precede REDS, while in others, it may develop as part of REDS. Disordered eating is relatively prevalent amongst high-level athletes. Among elite adult athletes, about 20% of females and 8% of males have disordered eating. Some sports are associated with a higher prevalence, and these tend to be those where there is a perceived advantage in being light, such as with cycling or fell running, or where there is an aesthetic focus, such as in gymnastics or performing arts, such as ballet. Now, in 2014, the British Journal of Sports Medicine told us that REDS can affect many bodily systems with both short-term and long-term health consequences, including increased cardiovascular risk. Now, if you look again at the written pearl, then you can see that the diagram with all the 9 chunky arrows on it has been built on with some text boxes which each of the arrows point at. These text boxes contain examples of health consequences for the different body systems. So mental health has poor sleep and depression. Menstrual has erratic or absent periods. Bone has stress or fragility fracture. Endocrine has elevated cortisol. Metabolic has reduced resting metabolic rate. Growth has reduced protein synthesis. Immune has reduced immunity. Cardiovascular has adverse lipid profile. And finally, gastro has nausea and abdominal pain.
So just to focus in a bit on the hormonal and metabolic imbalance happening here. Reduction in energy availability can interfere with GnRH secretion from the hypothalamus, and that restricts pulsatile LH secretion. And that can cause something called functional hypothalamic amenorrhea. And there's an article all about that topic on Red Whale Knowledge if you want more details. And rapid or significant fat mass reduction can also alter menstrual function, which brings us to our second pitfall. It's not normal to suffer menstrual disturbance due to levels of exercise. And it's not normal for the male version of this to happen due to exercise either, which is loss of morning erections. Either of those may indicate the presence of hypogonadotropic hypogonadism, and both are red flags.
Now, looking at bone health a bit more closely, estrogen and testosterone, present in males and females, promote mineralization of bone. low testosterone levels are associated with low bone mineral density in males. The British Journal of Sports Medicine in 2014 told us that in female athletes, the osteogenic effects of exercise are attenuated in the presence of chronic amenorrhea. These changes increase the risk of stress or fragility fracture. In 2019, the BMJ Open Sport and Exercise Medicine told us that relative energy deficiency has been shown to induce a rate of bone mineral density loss similar to that seen in astronauts who perform 2 hours a day of gravity-simulated exercise on the International Space Station.
Wow. And REDS can be difficult to recognise because it often presents with vague symptoms. It may be harder to spot in male athletes and in the absence of weight loss. So it's a diagnosis of exclusion. And on that note, here's our third pitfall. REDS can sometimes occur in athletes with a normal BMI. We think that this only applies to athletes, not non-athletes, and we say this because it's likely to apply to those with very low body fat levels but high muscle mass, making BMI normal.
What about athletes who say they've hit the wall?
Yes, I've heard that saying quite a lot, the concept of athletes hitting the wall. And there is another great diagram in the written pearl which shows our REDS wall, and some of the bricks in that wall are injuries, depression, poor concentration, poor training response, falling strength, irritability, reduced endurance, mental disturbance, that loss of morning erections, fatigue, and increased minor illnesses. So what do we do if we suspect REDS, Nick?
Well, if we suspect REDS, then we should consider eating disorder screening and the following tests. So for everyone in whom we suspect REDS, then we should do a full blood count, thyroid function, ferritin, B12, vitamin D, 9 AM cortisol, prolactin, LH and testosterone. And then in those assigned female at birth in whom we're suspecting REDS, then we should also check FSH, estradiol, and do a pregnancy test. We should also consider a celiac screen and or calprotectin if there are GI disturbances, and a bone density scan if the patient is at higher risk of osteoporosis on fracture risk assessment, for example, previous fracture, or if they're amenorrheic. So that's quite a lot of tests for us to do, which leads us nicely into the fourth pitfall, which is that normal blood tests do not exclude a diagnosis of REDS. If we do end up with a patient who has REDS, Ali, then what do we do?
Well, Nick, the aim is to modify diet and exercise behaviour, increase energy availability, and normalise weight, which is a lot easier to say than it is to do. So we're probably going to need some help. Ideally, this should be done through a multidisciplinary team with input from a sports physician, dietitian, and psychologist. We might also want to signpost our patient to resources such as the British Association for Sport and Exercise Medicine's Health for Performance website and Project RED-S. So we'll put a link to both of those in the show notes. And research suggests that increased energy status should lead to periods returning in women within months, but bone mineral density can take years to recover. So to facilitate bone health, we also need to optimise our patients' calcium and vitamin D intake.
Would combined hormonal contraception, aka CHC, help?
Well, with that one sentence, Nick, you've fallen into pitfall 5.
No, how?
Well, it's a big no. We should not prescribe the CHC to stimulate or control the menstrual cycle.
Why is that?
Well, all you're going to achieve by prescribing the combined pill is a false withdrawal bleed, which can mask the problem. And studies have found that the combined pill or the CHC is not associated with improved bone mineral density in amenorrheic athletes. And actually, it might worsen bone mineral density because it doesn't normalise the metabolic factors that are impairing bone health.
So at the risk of making myself look even more like a fool, is there any role for hormones?
Well, yes, sometimes. So we might use topical estrogen for symptoms of vaginal estrogen deficiency, so things like dryness, dyspareunia. And our secondary care colleagues might use hormones in the treatment of subfertility. And there's some role for hormones in impaired bone health only if amenorrhea and bone density are unresponsive to non-drug treatment. So there's no published data examining this, but the consensus guidelines suggest using transdermal HRT in that situation. And exact details of that are in the written article, but we think you'd want to have a low threshold for involving secondary care. And what about bisphosphonates, Nick? Can they help?
Well, there's little data looking at the role of bisphosphonates in treating low bone mineral density with or without fractures in athletes. Concerns exist regarding the use of an off-licence treatment in premenopausal women, the risk of teratogenicity in the event of pregnancy because bisphosphonates have a long half-life, also the association with atypical femoral fractures and osteonecrosis of the jaw, and because of all that, this would be a specialist decision. So here are your learning points for relative energy deficiency in sport, or REDS. It may affect physically active males and females, and it's due to low energy availability.
Early recognition is needed to prevent progression, but it can be hard to spot. Menstrual irregularities, or amenorrhea, are not a normal response to athletic training.
First-line management is to gain weight and restore energy balance through diet and exercise modification. Don't prescribe combined hormonal contraception to manage the condition. So that's the first one done. So how are you doing, Ali?
I'm good, thanks. I think I'm ready to go with another.
Well, just before we do, we're going to do that in 2 seconds, but I just thought we'd say hello quickly to everybody that's listening in Denmark, because we have been number one in the Apple Podcasts Danish medicine chart for the last week or so, which is just amazing. So thank you, everybody that's listening. Tak is how you believe how you say that in Danish, and hi is also hi in Danish. So hi to you, and thanks for listening. So that actually got me thinking. So where are you at the moment when you're listening to us? In the podcast app that you're listening on, if you click on the episode, it says send us a text message. So send us a text message, please. Tell us who you are and where you're listening to us from, and say hi. And we'll see whereabouts in the world you are. So there we go. Shall we do our next pearl?
Yes, please.
Okay. So we're moving now on to familial hypercholesterolaemia. And this one took me 14 minutes and 48 seconds to read, which sounds a bit like a cup of tea and a slice of lemon drizzle cake to me, but only, of course, if you've done your daily movement snack first. So Ali, what did this one mean for you?
Well, Nick, for me, there's sort of two opposing things when I think about familial hypercholesterolemia. There's this idea that the full criteria for who we need to refer are quite complicated. So there's something I'm always going to look up. So I feel kind of relaxed about that as long as I know where to look it up. But then actually, the pearl made me realise I need to be super clear in my head about which scenarios I need to look at those criteria in, because in the moment when I'm filing bloods or taking a history, I need to make a decision there and then about whether to consider the condition in more detail. So that's kind of something that I need to hold in my head, and the pearl has helped me get clearer about that.
Brilliant. That sounds good.
Yeah. But Nick, why is this important? Why does familial hypercholesterolemia even really matter?
Well, Ali, this is really important. It really matters. In 2009, the BJGP told us that by the age of 60, 50% of men and 30% of women with familial hypercholesterolemia will have had an MI. A year earlier, in 2008, the BMJ told us that treatment returns cardiovascular risk to near population risk. However, bringing us right up to date, the BJGP in 2024 told us where we come in, because they said that over a third of people with familial hypercholesterolemia in the UK are undertreated, leaving them at increased risk of cardiovascular events. So how common is it, Ali?
Well, according to the BMJ in 2023, worldwide it affects 1 in 310 people. And most familial hypercholesterolemia genes are inherited in an autosomal dominant pattern. Homozygous states are rare, but they do exist and they need very specialist management. Liver transplant might even be considered. And the BJGP in 2024 told us that in the UK, the prevalence is actually about 1 in 608, which is less than the worldwide figure I just quoted, suggesting that familial hypercholesterolemia in the UK is under-recognised in primary care. So again, this is something we can help with. And the aim of treatment is to reduce LDL by more than 50% from pre-treatment levels. And Lipids Clinic will also do systematic cascade testing to identify other family members with the condition. And this should definitely be a secondary care thing. A 2012 BMJ review suggested a just tell your relatives to get tested approach is not effective. And Nick, there has to be some nice guidance on this, surely.
There absolutely is, you'll be pleased to hear. The NICE Familial Hypercholesterolemia Guideline, which is NICE 2008 CG71, was last updated in 2019. And a couple of recommendations caught our eye. Firstly, we should systematically search our records for people at high risk of familial hypercholesterolemia. And that's people with a cholesterol of more than 7.5 if they're under 30 years old, or more than 9 if they're 30 years or older. Secondly, the Dutch Lipid Clinic criteria can be used as an alternative to the Simon-Broom criteria to make a diagnosis of suspected familial hypercholesterolemia in primary care. Now, if you've ever seen Lucy Jenkins teach this on a face-to-face course, then you'll have seen her say that she could never remember if it was the Simon-Broom criteria or the Simon-Broom criteria, because one of them was a Blue Peter presenter in the 1980s who lived on a farm in Derbyshire, and the other wasn't. So once and for all, we can confirm that it was Simon Groom who was the Blue Peter presenter, and the Simon Broom criteria are what we'll be talking about here. So, NICE asks us to do two things. Firstly, systematically search our records for those who have elevated cholesterols but have not been identified as having familial hypercholesterolemia. And secondly, identify new potential cases when filing blood results or talking to patients about their family history. We also need to remember that when measuring LDL, we should do two readings because of biological and analytical variations in levels. NICE doesn't give us any indication about the interval needed between these readings. Thanks, NICE. If someone has a known mutation, we should refer regardless of the LDL. It's really worth looking at the written pearl here because we've summarised the NICE guidance as a GEMS, a guidelines and evidence made simple, which you can download as a PDF and print off if you'd like. So make sure that you do that within 3 months of the release of the pearl.
I love GEMS. I've got loads of these printed off and laminated at work. I've got them as PDFs saved on my desktop, so they're always there when I need them. And at the top of this GEMS, it tells us how to identify new potential cases based on cholesterol levels or personal or family history. And for me, these are the important bits to remember based on either those history or cholesterol levels. From the history, if there's coronary heart disease under 60 years of age in the patient or a first-degree relative, then we need to assess the likelihood of familial hypercholesterolemia using either the Simon-Broom criteria or the Dutch Lipid Clinical Network criteria. And just as a quick reminder, first-degree relatives are parents, siblings, and children.
And from cholesterol levels in those more than 16 years old, if the total cholesterol is more than 7.5, then we need to assess the likelihood of familial hypercholesterolemia using the Simon-Broom criteria or the Dutch Lipid Clinical Network criteria.
NICE also tell us to do a systematic search for those at high risk. So those with a total cholesterol of greater than 9 if they're 30 years old and over, or greater than 7.5 if they're under 30 years old. But remember, those are just the very high risk people that we're searching for systematically. And actually, as Nick has just said, any adult we come across with total cholesterol greater than 7.5 needs their likelihood of familial hypercholesterolemia assessed.
And we suspect homozygous familial hypercholesterolemia if the LDL is more than 13 and the patient is 16 years or older, or if the LDL is more than 11 if the patient is under 16 years old. If these criteria are met, then we just refer as a suspected case of homozygous familial hypercholesterolemia. We don't need to use the Simon-Broom or the Dutch criteria here.
Okay, so just to clarify where we are up to on the GEMS, we refer for genetic testing, management and cascade testing of relatives if the Simon-Broom or the Dutch Lipid Clinical Network criteria are met, or if there's homozygous disease suspected. And Nick, we've mentioned them a few times now, so what are the Simon-Broom criteria?
I thought you'd never ask. So this is something that you're likely to look up when you need it. But to give you an overview, whether you meet this criteria is based on your total cholesterol and LDL and any history of tendon xanthomas or MI in the patient or a first or second degree relative. And you'll need the age of the person when they had the MI. Also, it's going to be if there's any history of high cholesterol in a first or second degree relative. So what about the Dutch Lipid Clinic Network criteria, Ali?
Well, the short answer is that, again, you're likely to be using something like an online calculator or the table in the Red Whale Gems to calculate this. But I'll run through briefly, again, what you need to know to calculate it. And before I start, it's worth saying that for the purposes of the Dutch criteria, premature is defined as males under 55 years old and females under 60 years old. So you score points for having a first degree relative with premature coronary heart disease or cardiovascular disease, or with a raised LDL, or with tendon xanthomas, or with corneal arcus. And you can also score points for a personal history of premature coronary or cerebral or peripheral arterial disease, or tendon xanthoma or corneal arcus. And your own LDL level will score you some points as well. And after all of that, we refer if the Simon Broom criteria are met, or if your score on the Dutch lipid criteria is greater than 5. And just to note, those with a confirmed genetic mutation automatically meet the threshold for referral in both of the criteria. They don't need anything else. So which out of the two criteria should we use, Nick?
Well, nice say that either can be used. Simon Broom is easier, but it's based on a UK database, which was started in the 1980s. The BMJ in 2023 suggested it may not be as applicable to other populations, including Asian populations, who tend to have lower cholesterols. Referral should be offered to all with suspected familial hypercholesterolemia, and this is for initiation of treatment, assessment of personal and family risk, cascade testing to identify asymptomatic relatives, and if there are symptoms or signs of coronary heart disease, then we should also refer to a cardiologist. In those with suspected homozygous familial hypercholesterolemia, then we should refer to a specialist centre because LDL apheresis or liver transplant may be offered.
What's LDL apheresis, please, Nick?
I thought that might just slip under the radar. So LDL apheresis is a bit like dialysis, but it's for cholesterol. Blood is taken out of the body and it's passed through some special filters to remove the LDL cholesterol along with lipoprotein A and triglycerides, and then it's returned back to the body. So there you are. What about more conventional management, Ali?
Well, as we mentioned earlier, the aim in management is to reduce LDL by more than 50% from pre-treatment levels. And that's achieved through all the usual lifestyle advice, so smoking, diet, activity, weight management, alcohol. And we should never use a risk estimator, such as QRisk2 or QRisk3, to assess risk in familial hypercholesterolemia, as these tools will significantly underestimate risk. And then for drug treatments, statins are first line in adults and children. And ezetimibe may be considered alongside statins or as monotherapy if statins are not tolerated or contraindicated. That comes from a NICE technology appraisal in 2016. And the treatment in familial hypercholesterolemia is for life. PCSK9 inhibitors might be initiated by a specialist if certain NICE criteria are met. And if you want to know more about these newer drugs, they're covered in the Lipids and Statins article on Red Whale Knowledge. And then there are some special considerations in women of childbearing age. NICE say the combined pill is not contraindicated for contraception, but it might increase cardiovascular risk, so they say alternatives may be preferred. And statins are not recommended during pregnancy due to the risk of congenital malformation or during breastfeeding, but women can breastfeed on bile acid sequestrants. And in children with familial hypercholesterolemia, the specialist will usually offer statins by the age of 10 or at the earliest opportunity after that.
All patients with familial hypercholesterolemia should have an annual review, and at that review we should check smoking status. NICE doesn't mention other CV risks such as blood pressure or lifestyle, but it's logical to include all of that. We should also check LDL levels and review medication side effects and compliance. We should review the progress of cascade testing and update the family history, such as new cardiovascular events, things like that. We should also look for symptoms or signs of cardiovascular disease and consider doing an ECG if it's indicated. Now, looking back through the GEMS and the different criteria, I can see that tendon xanthomas are important. But what about xanthelasma?
Yes, so just as a little reminder, xanthelasma are those yellowish deposits in the skin around the eyes that we sometimes see. And only about 50% of people with xanthelasma actually have a lipid disorder, so they don't make it into the criteria for assessing familial hypercholesterolemia risk. The other causes of xanthelasma are type 2 diabetes, hypothyroidism, diet, and excess alcohol intake.
What if people don't meet the criteria that we've been discussing?
Well, yes, clearly some people who have dyslipidemia will not meet the criteria for familial hypercholesterolemia, for example, those with hypertriglyceridemia. And although the NICE guidelines don't offer any advice on the management of those people, it would seem sensible to refer them to because they might have another lipid disorder.
So the killer question then, does treating those with familial hypercholesterolemia make a difference?
Yes, it does. So obviously it would be impossible to do a randomised controlled trial allocating some people to statins and other people to a placebo because of the ethical implications. But in 2008, the BMJ published a study that was able to look at patients who started treatment immediately compared with those in whom there was a delay in initiating treatment. The study involved over 2,000 patients in lipid clinics diagnosed with familial hypercholesterolemia, and the mean follow-up was 8.5 years. And for MIs, risk reduction was 76% in the early treatment group compared with the delayed treatment group, meaning that risk of MI in the early treatment group was brought down to a level similar to that of the normal population. So this study confirmed that early treatment reduces risk of MI significantly, almost to population risk. And Nick, what about the evidence around treating children?
Well, the New England Journal of Medicine in 2019 published a study which was a 20-year follow-up of 200 plus children with familial hypercholesterolemia and their siblings. It showed that with treatment, there was a dramatically lower rate of CV events and deaths compared with their parents at a similar age. At age 39, for those who had been treated since childhood, there was a 1% risk of CV events compared with 26% in their parents at the same age. CV mortality rates were 0% versus 7% in their parents. This was on a background average fall in LDL of 32%. Now, all of that is great news and a reminder of why it's so important to cascade test and identify affected families early. So here are your learning points for familial hypercholesterolemia. Consider the diagnosis of familial hypercholesterolemia in anyone with a total cholesterol of more than 7.5 and then assess them against the Simon-Broom or Dutch lipid clinic criteria and refer if appropriate.
Systematically search for any patients who are under 30 with a cholesterol greater than 7.5 or 30 or over with a cholesterol greater than 9 and assess them against the Simon-Broom or Dutch lipid clinic criteria.
Refer anyone with suspected homozygous disease, so that's 16 years or older with an LDL of more than 13 or under 16 years with an LDL of more than 11.
Aim for a 50% reduction in LDL on treatment. Cascade testing is required, including testing any children who may be affected. DNA testing should be used when a family mutation is known.
Don't use CV risk calculators as they significantly underestimate CV risk. Offer specialist referral to all for management and cascade testing. Remember, early treatment significantly reduces the risk of having an MI. Now then, next week we're talking about otitis externa and otorrhea. So here's your £1 million question. It's down to you and you alone to win yourself a virtual million. And you can play along as you listen to this on whichever platform you're listening on. Under the episode title, it says, send us a text message. So send us your answer and your name. And if you are the first one to get it right, then we'll give you a shout out next week. Give it a go. Last time there were a few correct answers, but not as many as you'd think. So it's absolutely worth a go. So here's your question for a virtual £1 million. Regarding cholesteatoma. This is a condition which is easily missed. Cholesteatoma tends to affect the upper part of the tympanic membrane and is more common in patients who have recurrent infections. It can present with chronic painless ear discharge and reduced hearing. How often would a GP with 2,000 patients expect to see a new case? Is it A, every 2 years, B, every 5 years, C, every 7 years, or D, every 10 years? And the answer is going to be revealed in next week's episode. Time now for our primary care superheroes.
Our first nomination comes from Michael. He'd like to nominate Sandar Hlang. He says, Dr. Hlang was my GP trainer when I completed my final year of training. Full of knowledge, committed to patients and her trainees, very generous with her time, and is as passionate and enjoying of her trainees' success. How lovely is that?
Oh, that is fabulous. And the next one is from Doug, and he nominates Dr. Andreas Erhardt in Hirwaun, a small rural practice located at the head of the Cynon Valley in Wales. And he has managed to keep it going as a partner lead despite issues with retirement and recruitment. And Doug says, I so often wish the patients knew the time and effort that he puts in so that they still have a local GP practice when so many others have closed or forcibly merged in our area. So thank you for that nomination. Now, if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale Pod members. How do you become a member, I hear you ask? Well, if you're listening to us, then you are part of our pod. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get 10% off. And here's a small print. The discount is only for this product and it won't work on anything else, no matter how hard you try. Please also note that this voucher code is all one word and all lowercase, Red Whale Pod.
If you've enjoyed listening, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. If you can spare a little more time, then please leave us a nice review. And because of the way the algorithms work, it means that other people just like you can find us.
And of course, putting algorithms aside, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes and all the links are in the show description on your preferred podcasting platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. And if you want us to see something about the podcast, then please use #RedWhalePod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@redwhale.co.uk. And until next time, I'm Ali Smith.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work so we're with you when you need that extra bit of information or reassurance.
Take care and look after yourself. Bye-bye.
Goodbye.